Thank you, Dr. Vadivel, for excellent presentation. Now we will move on to the next presentation, which will be on narrow QRS ECG based approach. By narrow QRS, we are talking about tachycardias which have a QRS with less than 120 milliseconds. The differential diagnoses are limited. The most common narrow QRS tachycardia we are going to see in clinical practice is going to be a sinus tachycardia, AVNRT reentrant tachycardia, which is the most common pathological form of narrow QRS tachycardia. So next could be a orthodromic AV reciprocating tachycardia, or we call it as a AV reentrant tachycardias, and atrial fibrillation and atrial flutter, and some unusual VTs can be narrow QRS, but we are not going to go into detail about that. So if you ask me the most common narrow QRS tachycardia you're going to see is a sinus tachycardia. If there is an underlying cause, you try to treat that. The most common pathological form of narrow QRS tachycardia is going to be a AV nodal reentrant tachycardia, or what we call as a AVNRT. Whenever you see a narrow QRS tachycardia, you have to look at the P waves. That's the most important thing. The second point you will always see is a PR and RP relationship. This will help you to make a diagnosis of a narrow QRS tachycardia. If you look at narrow QRS tachycardia, you broadly divide them into two categories. One is a irregular and another is a regular. The regular narrow QRS tachycardias are AV nodal reentrant tachycardias, AV reentrant tachycardias, and atrial tachycardias and flutters with fixed blocks. The irregular ones, the most common narrow QRS tachycardia, which is irregular, is atrial fibrillation, followed by an atrial flutter with a variable 2:1, 3:1. These kind of fixed blocks are not there, but patient has a variable blocks where you can see a irregular atrial flutter secondary to variable blocks. So if you look at the atrial and ventricular rates, sinus node can give out around 50 to 180 beats per minute, and AV nodal conduction is the most important determinant of ventricular rate. In a healthy young patient, it can go up to 200 beats per minute. In an older patient, about 150 beats per minute, 150 to 180 beats according to the adrenergic drive of the particular patient. Ventricles can give a heart rate close to 40 beats per minute. We see this kind of a escape rhythm when we have a patient with complete heart block kind of a situation. So the key questions in a narrow QRS tachycardia is, as I told you, first thing you have to look at is it regular or irregular? Second one, make sure it's a narrow QRS tachycardia. By definition, narrow QRS tachycardias with less than 120 milliseconds. That is, if the small squares, if your QRS width is less than or equal to 3 small squares, you are talking about a narrow QRS tachycardia. When it's more than that, we call them as a broad QRS or wide QRS tachycardias. And another thing you have to see and identify is there is a P wave before each QRS. This is the most important point which is going to help you in diagnosing this. As I told you, the most important thing you are going to look at in a narrow QRS tachycardia is PR and RP relationship. Unlike a sinus rhythm, your tachycardia ECG will not clearly show a P wave. You have to identify a P wave by looking into the ST segment or in the PR segment area. You will usually see a small deflection, which is not usually you see in a ST segment. You see in the ECG here, you can clearly see some small deflection here, small deflections here in the ST segment area, which is not a part of a ST segment. This is a P wave which has come after the ST segment. Same way you see here, after a ST segment, there is a small negative deflection, which is not part of a ST segment, which is a P wave which is seen clearly. So when you you see that, you try to measure the relationship. You follow the previous R wave to following P wave and continue this from the P wave to R wave. So you look at the R wave, follow the P wave, and look at the next R wave. So the first one, R to P, gives you the RP interval. The P from R give you a PR interval. So in this example, you have a RP interval which is very short, while PR interval is longer. So you are talking about a short RP tachycardia. The PR interval is longer than the RP interval. Otherwise, your RP is the shortest here. So you talk about a short RP tachycardia. Look at the second example. You have R and there is a P. So R to P and again you are measuring P to R. In this example, you can see that RP is longer than the PR interval. You are talking about a longer RP tachycardia. So the moment you identify this, your differential diagnosis become much easier. So the most common form of long RP tachycardias are sinus tachycardia, and pathologically, if you look at, it's a atrial tachycardia. For understanding sake, I can tell you that if you see a long RP tachycardia, most commonly you are dealing with a atrial tachycardia. Short RP tachycardias, most of your paroxysmal supraventricular tachycardias are going to be a short RP tachycardia. The most common form is a typical AVNRT, and most of your pathway mediated tachycardias will be a narrow QRS tachycardia. So if you make it simple for you, the moment you measure a RP interval and PR interval, if your RP interval is shorter than a PR interval, you're talking about short RP tachycardia. And most common short RP tachycardia you are going to see in clinical practices, AV nodal reentrant tachycardias and AV reentrant tachycardias. When your RP interval is longer than the PR interval, you are talking about a long RP tachycardia. The most common pathological variant of this particular form would be a atrial tachycardia. This slide may look little complex, but it's a very simple algorithm. I'll go through this. The moment you see a narrow QRS tachycardia, that is QRS duration less than 120 milliseconds, you look at the regularity. If you see the tachycardia is irregular, your tachycardia is not regular, then you are talking about atrial tachycardia, atrial fibrillation, or atrial tachycardia flutter with a variable block. So your differential diagnosis becomes easier the moment you see a irregular narrow QRS tachycardia. Next, what you are going to see, I already told you your QRS and ST area, you clearly look at if you are able to see a P wave. If you are able to see a P wave, or if you are not able to see a P wave, you are not able to see a P wave, you look very carefully in the tachycardia ECG, still you are not able to see a P wave. The most common narrow QRS tachycardia where you cannot see a P wave is a AV nodal reentrant tachycardia. This is important because AV nodal reentrant tachycardia, if you understand the mechanism, the tachycardia comes from the AV nodal area, in the junctional area. So your atrium and ventricle are activated simultaneously. So when you see a AV nodal reentrant tachycardia, what happens is your atrium and ventricle are activated simultaneously. So your P wave may be inside the QRS. That's the reason you are not able to see a clear-cut P wave. So whenever you are not able to see a clear-cut P wave in a PSVT, then you are talking about a AV nodal reentrant tachycardia. Next one is you look at the atrial rate and a ventricular rate. You have seen a P wave, you have seen the QRS. Your P waves are more than QRS numbers, then you are talking about a atrial tachycardia or flutter. So the chamber which is driving the tachycardia is the atrium because your atrial rates or P waves are higher than ventricular rates. If your P wave rates and ventricular rates, P and QRS are equal, then look at the RP interval. This is what I told you earlier. You have a short RP tachycardia, a long RP tachycardia. You see a long RP tachycardia, as I told you, the most common long RP tachycardia are going to see is atrial tachycardia. If you see a short RP tachycardia, if your RP interval is very short, that is less than 70 milliseconds. For your understanding sake, it's less than the 2 small squares. You are measuring your RP interval. Your RP interval is less than 2 small squares in the ECG. That is AV nodal reentry. The explanation remains same because your atrium and ventricle are activated simultaneously in a AV nodal reentrant tachycardia. Your P wave may not be seen, or if you're able to see a P wave also, it will be very close to the QRS complex. So whenever you see a very short RP tachycardia where your RP interval is less than 70 milliseconds, then you are talking about AV nodal reentry. When you have RP interval is more than 70 milliseconds, this could be a AV reentrant tachycardia. So I think I was clear. So next one we'll see is, as I told you, most of your narrow QRS tachycardias, they arise in the atria or at the junctional area. The maximum rate of a PSVT is dictated by the AV node because most of your AV tachycardias are conducted through the AV node. So as fast your AV node can conduct, that's the speed of your narrow QRS tachycardia. So if you have a regular narrow QRS tachycardia with a P wave, one possibility is sinus tachycardia, which is a long RP tachycardia. Irregular narrow QRS tachycardia without P waves, you are not able to see a clear-cut P wave, it could be atrial fibrillation. All other regular narrow QRS tachycardia, you can differentiate by the algorithm which I already shown you. You just look at this ECG. You have 3 leads here. You see if I'm a narrow QRS tachycardia, your QRS with this less than 120 milliseconds. This is very regular. And if you measure the RP interval, if you see the RP interval, R to P and P to R, your RP interval is definitely longer than the PR interval. This is sinus tachycardia. This patient, you should have a 12 lead ECG. The difference between a sinus tachycardia and any other form of a long RP tachycardia is your P wave morphology should look sinus. Your inferior lead P wave should be positive. Your AVR should be negative. Your lead 1 AVL will be positive. If your P wave morphology resembles sinus, at the same time you have a long RP tachycardia, then you consider a sinus tachycardia. So the sinus tachycardia, P wave will be there before every QRS. It will be regular. Usually you see a sinus tachycardia at a rate less than 150 beats per minute. Next will be a small case history. A 32-year-old female is treated in the emergency room for palpitations. The first ECG is the tachycardia, which I am going to show, and second one is after adenosine. You are going to identify what is the arrhythmia. So this is the tachycardia ECG. If I put your algorithm in place, you can clearly see a narrow QRS tachycardia and QRS with this less than 120 milliseconds. It's a regular tachycardia. If you look at the RP interval, if you are very careful, you see here, I am not able to see a clear-cut RP interval. So I may say that I'm not able to get a P wave clearly. I'm going to see a sinus ECG here. You see the sinus ECG here. The most important thing you have to look at is, look at the end of V1 after the QRS and end of QRS lead 2, 3 AVF. And go back and see your ECG. You see here, there is a small deflection here after the QRS, and there are some negative deflection in the inferior lead after the QRS. So if you compare that with the sinus ECG, there is no deflection after the QRS. There is no S wave here. So if you look at the tachycardia ECG, there is we call this a pseudo R and we call this as a pseudo S. These pseudo R and pseudo S are nothing but your retrograde P waves. Your P waves are coming just after the QRS and they are altering the morphology of QRS. We call them as a pseudo R and pseudo S. When you see this pattern is a typical of a AV nodal re-entry. This is so typical. You can see the small R in V1 and pseudo S waves in inferior leads. This is so typical of AV nodal re-entry. When you have a AV nodal re-entry, I've taken this patient for a radiofrequency ablation for curing the arrhythmia, but I'm not able to induce the arrhythmia inside the lab. What we usually do in a radiofrequency ablation, we take the patient inside the lab, we induce the arrhythmia, map the arrhythmia, and ablate the arrhythmia. But there are some times you may not be able to induce the arrhythmia in the lab. But if you have seen a clear-cut ECG, which is so typical of AV nodal re-entry like this, pseudo R and pseudo S pattern, you can go ahead and ablate slow pathway because this is so confirmatory of a AV nodal re-entry by just looking at the surface ECG. The second ECG, this is sinus rhythm. There is something which I think most of you would have observed. You can see a very short PR interval. Particularly, you can see your inferior lead here. There is a short PR interval followed by a delta wave. This is typical of a WBW syndrome. So WBW syndrome, you have a short AV conduction secondary to excitation of ventricle at the site of a pathway insertion. You will have bizarre looking upstroke of QRS because there is a conduction both from pathway and an AV node. So you look at conduction in the QRS, you will see both pathway conduction and a AV nodal conduction. Your QRS is wide because there is a early initiation of ventricular depolarization producing a wider QRS. So this is all how it looks like. Your PR interval is short. Your P upstroke of QRS is slurred, what we call as a delta wave. So one thing you should, like, for the sake of understanding, I'm telling you, one thing you should be very careful whenever you see a atrial fibrillation syndrome. Although this is not part of a narrow QRS tachycardia, most commonly what you see is a white QRS tachycardia because your tachycardia goes through the pathway. Your atrial fibrillation, when you have atrial fibrillation, your atrial fibrillation go to the accessory pathway and produces the wider looking irregular tachycardia. So that's a very important thing to know, because whenever you have a white QRS tachycardia which is irregular in a patient with a WBW syndrome, you are talking about a atrial fibrillation which is going through the pathway. This is very important because if you are going to give any drug which is going to block the AV node, which will increase the conduction across the accessory pathway, and patient can end up in a ventricular fibrillation. So next one is you can look at this ECG, the narrow QRS tachycardia. I'm not able to see a clear-cut P wave, but one thing is very clear. Particularly, you look at the inferior leads. Your inferior lead is showing a definite irregularity of the QRS complex. You are seeing a narrow QRS tachycardia which is irregular. As I told you, the most common narrow QRS tachycardia which is going to be irregular is atrial fibrillation. You can see a chaotic atrial activity at a rate more than 300 beats per minute. Usually it's irregular. Maybe sometimes it's difficult to pick up the irregularity if your heart rate is high. You may have to take a piece of paper and go on looking at the RR interval. Your ventricular rate depends on conduction through the AV node. Usually it is 150 to 180 beats per minute. If not on any drugs which are going to block the AV conduction like beta blocker or calcium channel blockers, your heart rate is usually in the range of 150 to 180. You will have a fluctuating, undulating baseline. You will not see a clear-cut P wave. As I already told you, if there is an accessory pathway, the AF can be very fast because AV node, as I told you, can conduct only at to the seat of 150 to 180 beats per minute. But your pathway does not have any control like that. So your AV, all the atrial impulses can go to the ventricle and patient can develop a ventricular fibrillation. So that's the reason you have to be very careful when the patient has a pathway and develops a atrial fibrillation. The next ECG, it's a very easy one. I think most of you would have picked up the diagnosis. You can see clearly here, there's definitely a narrow QRS tachycardia, and it's very regular. If you look at inferior leads, there is something which is very striking in the inferior leads. You see the inferior leads here? You can see more than one P wave here, and there is a pattern there. We call this a sawtooth pattern. It's very clearly you can see in the inferior leads, although and if you look at the V1, you're not able to see clearly a pattern like that. You are looking just like a sinus rhythm P wave kind of a thing, but you go and look at your inferior leads, it's clearly showing a sawtooth pattern. Sometimes this may be confusing. I always say whenever you see a tachycardia which is 150 beats per minute, you should always be careful about atrial flutter, because atrial flutter, the most common conduction is a 2:1 conduction. So when you see a tachycardia which goes at 150 beats per minute and you look at the screen, each and every beat is 150 beats per minute. If you have seen a sinus tachycardia, I think most of you would have observed that the tachycardia rate changes. The rate goes to 145, 148, 150, 156, something like that. It changes most of the time. But in a atrial flutter, if you put a monitor on and you just sit there and watch, it will be fixed at 150 beats per minute. The reason being, the atrial rate is 300 beats per minute and it's conducting a 2:1 conduction. That means your heart rate will remain at 150 fixed. Sometimes if you have a difficulty in identifying, is it a flutter or a sinus rate? Because you look at V1 here you look like there is a P wave here, maybe a sinus tachycardia kind of a thing. To make it, if you want to confirm it, there are two things you can do. One, you can give an adenosine. You give an adenosine, what happens? Your AV is blocked and very clearly see a flutter waves. You see the top portion here, the first ECG, there is a tachycardia going on. If you are looking at V2 and V3, you are not able to see any P wave, but just look at your inferior leads, you can clearly see a sawtooth pattern. So what they have done, we have given a adenosine and blocked the AV node. So this has brought out the flutter waves. You can clearly see a flutter waves here, followed by the QRS complex. So atrial flutter is a diagnosis. So atrial flutter is similar to atrial fibrillation, but atrial activity is more organized. Usually they will have a specific reentrant circuits in the right atrium or left atrium. The ventricular rate again will depends on AV conduction rate. It will be exactly at 150 or 100 depending on the conduction. If it is a 300 atrial flutter and you have 2:1 conduction, your ventricular rate will be 150. If it is a 3:1 conduction, your ventricular rate will be 100. But as I told you already, if you have an accessory pathway, you can go at 300 beats per minute. You can see a atrial conduction in the baseline. You will see a short tooth shaped flutter waves. They're very easily amenable to radiofrequency ablation. We have a very high success rate with flutters. So this ECG, again, you can see here, the heart rate is on tachycardia range, more than 100 beats per minute. You can see a narrow QRS and it's regular. So you're looking at a narrow QRS tachycardia, which is regular. Next one, I'll always do, look at a P wave. Just I am going and looking at the P wave. Yeah, we can see here in V1, you can clearly see a P wave. So the same way I'm going to see R, P and PR. So your RP interval is pretty longer compared to the PR interval. So you are dealing with a long RP tachycardia. Only doubt looking at this rate is it a sinus tachycardia? Is it not? No, it is not sinus tachycardia because you look at the inferior leads. Your inferior leads, your P waves are negative. In a sinus rhythm, because you have a sinusoid which is sitting at the top of the heart, your inferior leads will always record a positive P waves. But here, what you are seeing is a negative P waves because this tachycardia is coming from the lower part of the right atrium. So because they are coming from the lower part of the right atrium, your inferior leads are recording a negative P wave. So you have a atrial tachycardia here. Although it's not very fast, you have an atrial tachycardia running at a rate of 100 and 120 beats per minute. And most probably it's coming from the lower part of the right atrium. So you have a atrial tachycardia here. An atrial tachycardia usually varies between 150 to 250 beats per minute and usually does not require an AV nodal or infranodal conduction to initiate tachycardia, but you need a AV node to conduct the atrial tachycardia. Your AV node is going to conduct the atrial rhythm back to the ventricle. Your P wave morphology will look different from sinus and PR interval more than 120 milliseconds. So your PR interval will be longer. So one thing you can always be sometimes you can be confused when you have a tachycardia running at a rate of 100, 120. When you have a tachycardia, particularly for sinus rhythm, your PR interval usually shortens. Whenever you have a sinus tachycardia, your PR interval shortens. When you have a tachycardia where your PR interval is longer than the sinus rhythm, then most probably the atrial conduction, atrial activation is not from the sinus node. So to make it a little more understanding, you have a patient, you have a sinus rhythm ECG, PR interval is 150 milliseconds. The patient develop a tachycardia. And during a tachycardia, looking at the PR interval is 200 milliseconds. Sinus tachycardia, usually your PR interval shortens. But in the atrial tachycardia, your PR interval prolongs because your atrial conduction is not going through the specialized conduction system. So when you have a tachycardia, have a PR interval longer than the PR interval of sinus rhythm, or your P wave morphology is different from the sinus rhythm, you are dealing with a atrial tachycardia. You can look at the atrial tachycardia and identify from where it is coming. If you have upright P wave in V1 and negative in AVL, it is usually consistent with the left atrial focus. If you have P wave which is negative in V1 and upright in AVL, it is consistent with the right atrial focus. Adenosine may be help to diagnose the diagnosis if you can able to give an AV block and you are able to conduct block the AV nodal conduction. 70 to 80% of the time, if it is particularly if it is coming from a septum or CS os area, it can terminate with the adenosine. So the termination with adenosine will not differentiate you from a AV nodal reentrant tachycardia and AV reentrant tachycardia from atrial tachycardia. So atrial tachycardia can also terminate with the adenosine. You have other few long RP tachycardias. I'm not going to complete detail of all this because they are not very common. One is a sinus nodal reentrant tachycardia, where there is a re-entry inside the sinus node, and it can resemble a sinus tachycardia very much like a sinus tachycardia. But the difference between sinus tachycardia and sinus nodal reentrant tachycardia is usually a sinus tachycardia will start slowly. Patient will have a tachycardia and slowly comes down and stops. But a sinus nodal reentrant tachycardia, being a reentrant tachycardia, will have an abrupt onset and offset. Suddenly the tachycardia will start and suddenly will stop. So when you have a tachycardia which exactly resembles a sinus tachycardia, sinus rhythm, and has a rapid onset, abrupt onset and abrupt offset, you are talking about a sinus reentrant tachycardia. As I told you, because it comes closer to the sinus nodal area, your P wave will be as same as sinus. They are usually very much amenable to calcium channel blockers and beta blockers. Sometimes we can take them for a radiofrequency ablation. Another one is a syndrome of inappropriate sinus tachycardia. You will typically see a sinus tachycardia, but all the time heart rate is high. If you see a Holter, the lower rate, the minimum rate, whatever you would have seen would be less than 100, 120. So when you have a sinus tachycardia running all the time, see, sinus tachycardia has to be there when the patient has a evidence of any adrenergic stimulus or anything which is going to increase your sinus rate, maybe a fever, is exerting himself or something like that. But the patient is at rest, doing nothing, still sinus rate is very high, then we think about inappropriate sinus tachycardia. Usually you can treat them with beta blockers. A lot of time it requires high dose. One drug which you use more commonly nowadays is a ivabradine, which can have a good control over this tachycardia. Because it comes from sinus, it's very difficult to ablate this tachycardia. Although we try to modify the sinus nodal area, this is very difficult area tachycardia to ablate.